Good luck, Priyam.
Thanks, Chris.
It's just you and me here, so.
Yeah. What do you see on my screen? Do you see that little thing that says participants in Christopher Manieri?
Yeah.
Okay, you see everything.
I see the Medical Society of Delaware credit thing.
Good.
All right, you can just start. I'm ready.
Okay. I was waiting for your permission. Can you see me?
Did you mute me?
No, can you see me?
Yeah, I can see you.
Okay.
It's good. I'm gonna mute my mic.
Okay.
Hey, do you want to delay the Dr. Warner thing until tomorrow because it's going to be raining tonight?
Yeah, let's do it.
All right, I'll shoot her a text later today.
All right. She basically had mentioned that to me yesterday, but she's like, it might rain and we might have to cancel. So
yeah,
that sounds good.
I'm free tomorrow if you want to do it.
Okay.
Priyam?
Hey, Ruthann, how are you?
Hi. You doing all right?
Yep.
Okay.
You guys can see the screen. No issue seeing the screen or anything?
All right. Yeah, that's good.
Okay. Ruthann, I'm going to mute you now. Unless,
Okay.
yeah, everything's good from your end, though?
Yeah, I'm fine.
All right. Video quality's fine. Audio quality's fine?
Yep.
All right. Perfect.
Can you hear me?
Yes, sir.
All right.
Perfect.
Good. It's not so easy. The mute on this is not clear. I'd like everybody to mute so we don't have a lot of background noise.
They're going to come in muted. That was an option on the Zoom, so we
Great.
shouldn't have any issues with that.
All right, perfect. Priyam, where are you? Giving.
I'm home.
Right. I don't recognize that lamp from anywhere at Christiana.
Yeah. Take 1 second. Hey, are you logging in with your own computer system? Are you bringing your own? Are you using your own laptop to log in? Yeah. Yeah, that's at 8:30. Yeah. You don't have your own laptop on you by any chance? Okay. I just if I need to give you the host functions because I think because of the I'm gonna have to, let me mute this. Because what? 1 minute. 1 minute, please.
You okay? What's the matter?
I'm having there's a issue that I think the new security rule basically doesn't allow for anybody to come in without having permission. So I just need somebody to accept everybody. Yeah.
Can you give it to me?
Yeah, I can give it to you, Ruth Ann. Can you take care of it?
Yep.
Okay. Never mind. Ruth Ann's got it. Thanks. Bye.
I don't have anywhere to go.
All right, perfect. So I'm going to give it to you, and if you see the people coming in, let me know if there's any questions. I'm going to make you the host.
Okay. Okay.
All right, so if you see the participants list, do you see that little thing with the participants list?
Yes, I'm starting to see heads.
Yeah.
I don't see a list. I see the people down the side.
Okay, there should be a little list with all the participants.
All right. So
Hover over the bottom, it seems to disappear.
hover over the bottom.
There's a whole list.
Michael Johns has entered the room.
Yeah. Or it's,
Admit. I
yeah.
got it. They
So
pop up.
yeah, I just need you to admit everybody like that. Is that possible?
Yep.
Okay, so you were it gave you a little thing that said he wants to come in, and you.
Yeah, it's a little pop up that comes up
So
down the bottom.
all right, perfect. I just need you to admit everybody because obviously I'm going to be doing the presentation. So
Yeah, I don't think you should be bothered with that.
yeah.
Multitasking, come on. Priyam, is this being recorded at all?
Yes, sir.
Good luck, Priyam.
Thanks, Dr. Freeland.
Mm. Mm. Am I not muted?
We have about 44, 45 people. I'm gonna probably extend it probably a little bit and let people join in on. Maybe start around 7:10ish. What do you guys think?
Yeah, was there a RSVP list? Do you know?
There was no full RSVP list.
Maybe just give it a couple minutes and start at 7:05.
All right, yes, sir. Ruth Ann, you're still able to admit people, right? All right, it looks like we lost Ruth Ann. All right. I think we've got a quorum. I'm going to go ahead and start. So good morning, everybody. Can just a really quick just tech thing. I want to make sure that everybody can see the screen. Everybody that's coming in is muted. Please make sure that you're muted. I can mute you if there's an issue, but just make sure that you're muted when you come in. The default function is mute. I will open the floor for questions at the end of the presentation. Sometimes you can't see the unmute function. So all you have to do is kind of hover around the bottom of your screen and you'll see it. And then you just have to unclick your unmute function and you should be able to do that. Dr. Bennett, you can hear me okay?
Yeah, I can hear you.
Okay, perfect. All right. The only other thing is this is the Medical Society of Delaware slide for CME credit. I have this in the beginning here, and I'll also have it at the end. So in case anybody did not get it, I will show it at the end. I unfortunately am not able to email this slide out to everybody just because it wouldn't be an accurate presentation. So I was requested not to send that out to the group. But if there's any questions or if somebody needs to have it sent, just unmute yourself and I can show that again at the end. So welcome everybody, welcome to my grand rounds, and I give the floor to Dr. Bennett.
Yeah, thank you, Priyam. Priyam asked me to help him with this talk, but to be honest with you, he really didn't need any help whatsoever. He did an amazing job. And for those of you who don't know, he was actually assigned a completely different topic as all chief residents give surgical grand rounds. And he had prepared something else, but with no surprise, given his work ethic and his curiosity and diligence, he pivoted last minute in order to make this a more timely and educational lecture on the COVID pandemic and how we're going to recover from this. Priyam, took the challenge head on, not only as a doctor, but as a surgeon and as a leader. And it's no surprise that he's the administrative chief resident. And looking at his CV, it's quite impressive. It's peppered with all sorts of leadership roles that he's had since he's been in high school and going through college and medical school. Titles such as lead student manager, lead volunteer, lead advocate, president of different societies, such as the Society for Physicians for Human Rights, are all throughout his CV. And the list just goes on and on, from high school, where he was an Eagle Scout, to medical school. Priyam went to Virginia Commonwealth University for undergrad, and he won and then for medical school, and he won the VCU Leadership Award in medical school, which is the highest leadership award given by the university. And he also won the highest oncology research scholarship award twice. And so I'm still perplexed why he's a vascular surgeon instead of a surgical oncologist, but I've come to grips with that. Priyam also won the Dean's Merit Scholarship for Outstanding Performance during all 4 years of medical school, and then came to Christiana, where we're certainly honored to have him. So he ramped up his game even more when he got here. He was Resident of the Month. He won the Teaching Award several years in a row and participated in the LEAD program for residents, which you have to be nominated to participate in. And with no surprise, he became one of the co-administrative chief residents and then matched at Cleveland Clinic, where he'll be a vascular fellow. It's a very well-deserved position. So I've really enjoyed working with Priyam over the past several years, first as my resident, but then as my friend. And I know Priyam will accomplish very great things. I really look forward to seeing him reach his potential. And I think we should all be very proud at Christiana that we are part of his academic development. And with that said, I'd like to turn the talk over to Priyam. Thank you.
Thank you very much, Dr. Bennett. It was an honor. I really appreciate it. And thank you for all of your mentorship during this talk and over the last 5 years, sir.
Thank you.
Okay. Good morning, everybody. So I think that you guys should be able to see my screen now, and it should be our title of the presentation. Thank you for everybody for coming to this talk. I sincerely appreciate it. It's quite a different time right now. We're all here over Skype. There's over 50, close to 100 people in this presentation right now, all over the state. Some people are sitting in Wilmington, Delaware, such as myself. There's people in Newark and all over the state coming into this presentation, so I sincerely appreciate it. The title of my talk is The COVID Pandemic, Debriefing the Crisis and Reimagining Medicine. I chose this talk, and after, as Dr. Bennett mentioned, I changed my talk because I wanted to really talk about what we as physicians, as well as physician extenders and as a healthcare system did in this pandemic. And I think it's been quite amazing. And that's really why I want to debrief the crisis and really talk about this in a institutional and the systems level. And then really talk about going forward how medicine from here is going to change. So let's get into the talk. So first off, I have no disclosures that are noteworthy. Of course, I am a graduate of VCU and a big avid fan of VCU basketball, and I'm a diehard Eagles fan as well. So those are my only two real disclosures. I will be biased no matter what to those two teams. Like lots of talks, I'm going to start off with a quote. The quote's going to be from Winston Churchill. To improve is to change. To be perfect is to change often. And I think the reason that I chose this quote is because this is what we're doing, and we're doing it rapidly right now. Our institutional response, our global response, and our national response to the pandemic has been fast. We've responded very quickly, and it's been quite amazing. I know that a lot of people have lost their lives, a lot of people have gotten sick, but there has been a silver lining. And as a physician and an aspiring physician leader, I think that this is the amazing portion of this pandemic, is really watching our institution change. And that's really what I wanted to highlight in my talk today. So let's talk about what we're going to be really going through. So here's the overview. When you talk about a pandemic or any great challenge that comes any great challenge that comes to an institution and to leaders, we have to really talk about these 5 R's. First, we needed institutional resolve. We had to come together and resolve that we're going to get past this. The next is resilience, not only financially, but as an institution, as healthcare workers. Then we need to really talk about how are we going to return back to normal. From there, let's reimagine medicine. Let's talk about all the changes that we've already seen over the last 2 months and how we're going to go forward. And finally, with change comes reform, not only from an institutional level, but from a national and federal level, and the types of laws that need to be passed and other reforms that need to be done in order to really respond to this pandemic. So the first R is institutional resolve. What is resolve? Resolve is a top to bottom organizational support and a firm determination to overcome the challenges of the pandemic. I think we really did this as an institution and as a healthcare system. We came together and we said that we're going to find a way to get through this pandemic, which has been incredibly challenging. So how do we do that? How, as an institution, do we really talk about institutional resolve? So here we have institutional resolve in the middle of our mind map with 5 bubbles coming out from it. And I'm going to talk about each individually. The first is, in order to overcome this pandemic, we resolved to increase the supply and capacity. We also decided to adapt different care delivery models. We changed our resource allocation completely. We decided we are now firm on our evidence-based medicine, and we also need to find a way to take care of the non-COVID related challenges. So when we talk about institutional resolve, let's talk about the problem and what we need to figure out. So this slide right here is from the Institute of Healthcare Metrics and Evaluation, an independent global health research center at the University of Washington. What we see here and what the governor and all the healthcare leaders have seen is what we're facing as a problem. So there are a certain amount of beds that we're going to need for COVID patients, and there's a certain amount of ICU beds that are going to be available for patients. And then we look at a shortage. So we're using different metrics and different projections to say, these are the amount of patients that may be infected with COVID that the institutional needs to find a amount of beds available to take in this surge capacity and the amount of ventilators at the same time. So we saw the problem. and this is how we resolved to meet it. First off, we increased supply and demand. So how did we do that? We immediately started increasing the following. A, access to care. We increased our ICU beds. We also changed the HVIS unit into the CVICU in order to increase the amount of beds in the CVICU into COVID units. We also had to increase our medical equipment. So PPEs, ventilators, oxygen, and tests as well for COVID. We also needed to appropriately train our workforce. So we had to make sure that the right nurses were at the right locations and make sure we had enough ICU nurses to meet our change. So we did that. We also have to increase capacity. So freeing up and building alternative capacity, this included deferring elective procedures. This was major. Every day, if there's a number of procedures, 100, 120 procedures, 150 procedures being done at the institution, imagine the amount of PPE, ventilators that may be necessary, oxygen and other things that may be necessary. We had to defer elective procedures in order to increase our capacity, as well as use those operating rooms as a possibility for COVID surge. At the same time, as I mentioned, conversion of floors and other space in outpatient facilities. We didn't see that much at Christiana, but if you talk about in a national location, we look at the Javits Center in New York City and a lot of other convention centers that became COVID flux units in order to really help either take care of sick patients that had COVID or take care of patients that did not have COVID in order to allow the increased capacity for patients in the hospital that have COVID. We also had to fortify our supply chain. So how do we do that? So what we did was we established a supply chain conservation protocols. We really listed out the key supplies, equipment lists, and it looked at the usage rates that we were doing for certain things. And once we did that, we were able to say, this is the stuff we need to get. And these are the things that we need to save. So what do we do to save these, and what do we do to get more of these? And this includes PPE. And when we secure PPE and expand access to PPE, this doesn't just include our healthcare workers. It also includes the rest of any essential worker as well. One of the perfect examples of this is masks. As you guys remember, when we started our COVID response, we had to use the same mask for a week. Now the hospital has the ability to use a different mask daily. And that change right there goes and speaks about how we fortified our supply chain going forward. We also had to find new ways to obtain supplies direct from manufacturer, in-house production, sterilization, reuse, and donations. Some of the examples of ways that we found new supplies included, we had donations of thousands of essentials and goods. We also had, very importantly, we were able to make we were able to use a 3D printer to create these plexiglass boxes for COVID intubation, and they were called intubation boxes that were used in the operating room. It is phenomenal the way that we were able to find new ways to obtain supplies. So let's look back. We just took care of our increased supply and capacity. Now let's talk a little bit about providing evidence-based medicine and guidance. So this is our institution has to have a commitment to providing evidence-based medicine to the community. Some of the proven therapies is prone positioning, steroids when you have severe ARDS. Non-proven therapies, as we've seen, are hydroxychloroquine and azithromycin. Some of the investigational therapies are going to be remdesivir and convalescence plasma. So I really found this as a really important slide to explain exactly why I'm talking about providing evidence-based care. Everybody's reading that and saying, Priyam, we're physicians, we're physician extenders, we're a healthcare community. That's what we do on a daily basis. In a time of a pandemic, this is paramount. What we're looking here is all the locations that people are getting their news about the pandemic. This is incredible. Some of the places include local news, national news, state governments, federal governments. And down below is where the physicians and the health systems are really giving the correct information. This is not a political talk, but it's really important that we as a healthcare institution continue to look every day at the true evidence and provide the best evidence for our patients, because people are really looking for the truth, and sometimes that may not be provided by other outlets. I really wanted to put that into example here. So what we have here is what I have here is a chart that's going to explain the exact images and ideas of what happened. So what we're looking here is 2 images. The first one is chloroquine, the next one is hydroxychloroquine. And the orders of these 2 medications by people that were not healthcare providers. And this is completely apolitical. What you see here is that you see that Elon Musk first endorsed chloroquine and hydroxychloroquine. And there was a surge in both orders and buy of Amazon, eBay, and Walmart. Then the president endorsed this medication, and there was another large surge of expected queries as well as buying from Amazon, eBay, and Walmart. Then we started seeing the side effects of these medications and that these were not effective, and you can start seeing the decrease in the downtrend of these medications. That's why it's so important as an institution that it's paramount that we give and provide the best evidence-based medicine. Let's also talk about managing chronic diseases. So we are really, as an institution, trying to adapt and take care of the patients during the pandemic. These are the COVID patients. So we've done all this stuff, including increased supplies, get PPE to take care of our COVID patients. What about the other patients? So the Center of Disease Control and Prevention analyzed a sample of patients hospitalized with COVID-19, over 14 patients. Look at all these patients that had at least some other medical problem outside of COVID. The majority of them did. So we still need to take care of these patients and manage their chronic diseases. So basically, in a more large picture, we're taking care of the non-COVID related illnesses and challenges. So this includes medication refills, making sure that your diabetic has the right insulin supplies, making sure that all the test strips are filled. Everything is filled so that these patients aren't coming into the hospital and really filling up our ER and our hospital with these problems that could be managed at home. Televisits, I'm going to go into that in great depth, but these visits, especially on a primary care level, are the reason that these patients are not completely flooding the ER, which we're seeing usually on a day-to-day basis before the COVID pandemic. Next, we're really leaning on our ACO, or the Accountable Care Organization, eBright Health. This accountable care organization is really taking care of the patients that are the highest risk for readmission to the hospital. And we're really leaning on them to keep them out of the hospital during these times in order so that we can take care of the pandemic. And finally, one of the major things, especially from a surgical perspective, it is a surgical grand rounds at the end of the day, is canceling elective cases. There are a lot of cancer patients, there are a lot of other patients, including vascular patients right now, that we need to make sure that we find a way to meet their illnesses, their chronic illnesses, or their current illnesses in a way outside of the hospital. And so we've canceled elective cases, so we have to find different ways, whether it's neoadjuvant care and chemotherapy for a cancer patient, whether it's starting a maximal medical management for a vascular patient, finding ways to keep the patients out of the hospital. So we've really talked about increasing supply and capacity, providing the non-COVID related challenges, providing evidence-based medicine. Another important thing is resource allocation. I really want to thank everybody that's came to this talk, as well as everybody else in the institution, because resource allocation, it really begins with all of us. So this isn't just what we look at for resource allocation, is that what you need is more PPE and other equipment. So you're going to buy more of that, so there's less other stuff. For a surgical perspective, you buy more masks, more gowns, and you buy less staplers and vessel sealers. At the same time, from a staff perspective, there are certain outpatient organizations that are not right now open because of the pandemic. So we've allocated our human resources in different ways. I really appreciate the people standing at the hospital entrances that are taking our temperature, that are making sure that we're not sick when we come in, and all the other places that the staff has helped actually take care and bolster our healthcare organization to meet this demand. And finally, we have to adapt care delivery models. What does this mean? Well, I'll get into this much more during the telehealth period, but really we have to create different models to take care of different patients. So as I mentioned, the non-emergent procedures, but what about drive-through testing? That's how we can we can deliver health without bringing patients in the hospital. What about tents for COVID patients, so that we are able to take care of certain things before they come into the hospital, so we're able to try to risk stratify them. As an institution, what we did here was we resolved to solve this problem together, and we did an amazing job at it. So now let's talk about the next step in this entire pandemic that our institution used, which was resilience. So what is resilience? It's an organizational capacity to recover quickly from challenges of the pandemic. It's toughness to last through through these times. So let's talk about this in terms of a typical health systems operating margin. This isn't Christiana. I actually got this slide from McKinsey, who's been really consulting all over the country with different healthcare systems during this time. What you see here is that before, the number one, this box here is before COVID. So it's our normal, it's a hospital or healthcare system's normal operating margin. All of a sudden, there's a huge decline in operating margin because our elective patients, our ED patients, our ambulatory volume has significantly declined prior to COVID. It's a big ramp up. Then we start seeing a little bit of increase because there are, at least our hospitalizations have increased a little bit through pandemic. And then we start seeing, and as we start recovering from this pandemic, the surge. So what we see here is that the margin in the hospitalization increases significantly, where the elective recapture following COVID, and finally we go back to our baseline, which is after we kind of recaptured all of that stored margin and money that was kind of pent up or was lagging behind because of the COVID pandemic. At the same time, let's talk about the problems in terms of money. So when we talk about resilience, we're really talking about an institutional and a healthcare system's response to money. So what I have here is a chart really explaining how the healthcare system is getting money during this time, and the lack of financial reimbursements. So when we talk about COVID patients, this is a reimbursement chart from the Centers of Medicaid and Medicare. And what you see here is that from a professional standpoint, our hospital is charging about $7,000 for the care that we receive from the average commercial healthcare insurance, about $3,500 given back. And then when we look at Medicaid and Medicare, it's a much lower level of reimbursements. In terms of inpatient care, what we're looking at is about $65,000 in charge, and the commercial insurance is only reimbursing us about half of that, and Medicaid and Medicare are really reimbursing us minimal compared to that. So what we have is a huge amount of loss of margin and a large amount of increased expense without significant reimbursement while we're taking care of COVID patients. And these charts are for COVID patients. So we're taking a big loss as an institution from a financial perspective. How do we stay resilient, last through these tough times? First, we have to maintain our liquidity. What's liquidity? It's cash available. And second, we need to maintain solvency, which is possession of assets in excess of our liabilities. It's our ability to pay our debts. And finally, when we grow, we need to grow sustainably. So this is actually from our Christiana Care meeting last year in regards to what our goals were from a 3-year perspective. So a lot of you will call this as the road to 100 million over 3 years. So the Christiana Care for the first year saved 15 million. That was fiscal year 19. The goal was for fiscal year 19 was 10 million. So great, we saved 5 million more in fiscal year 19 than we were supposed to. The most important thing was in fiscal year 20, we were supposed to save 30 million. And in fiscal year 21, we were supposed to save another 60 million. We're gonna be leaning on these locations to find ways to save money in order to really maintain liquidity during these times. So we're gonna be finding different ways to really keep the cash on hand so we don't have a major issue with loss during the COVID pandemic. So at the same time, we're trying our own ways, but how else can we get help? Well, everybody's going to look at the government and say, what about the government? How is the government helping? And the most notable legislation passed is the CARES Act. So how does the CARES Act really help us as a healthcare system? First is that we got an institutional tax credit. Second off, there was a hospital reimbursement of about $100 billion related to COVID expenses. Third off, there was a reversal of scheduled cuts that were to Medicaid and Medicare. And this is major. So there was a planned about $11 billion cut that was going to happen over 3,000 hospitals in this country. These were scheduled cuts to Medicare and Medicaid. And thankfully, these cuts were reversed. So this will now help our institution in terms of reimbursements. Next, we're receiving the entire healthcare system in the country is receiving accelerated payments through Medicare and A and B. So even though they're very small compared to the costs that the hospital is occurring, at least we're getting the reimbursements a little quicker. And finally, there are very low percentage loans for healthcare institutions and businesses that have deferment of any interest rate and as well as low interest rate for these institutions. At the same time, we need to maintain solvency. So this is very important in terms of explaining where our debts. So when I talk about the assets or the ability to pay one's debts, one of the nice things is through the CARES Act and through maintaining liquidity, at this time, our hospital is doing an excellent job maintaining our solvency. And then finally, sustainable growth is going to be our long-term approach. So the institutions in the United States may need to dedicate resources to developing new models for serving Medicaid patients where the economics have been historically very challenging. So how do we capture these patients that have always been challenging in order to really somehow find a way to make sure that we grow sustainably and capture those patients where we might have incurred loss in the beginning? We also need to, at this time, when we grow, we need to really shore up our analytics department and our data. We already have an innovation center in the hospital that many of you have maybe seen when you're at Wilmington Hospital, but we need to create as many in-house innovations to save costs long-term. Oh, and telehealth, more to come on that. So let's go back and see where we are on our climb here. We showed institutional resolve. We've had resilience through the tough times. So, I mean, you can't go through an entire pandemic talk and not talk about how we're going to return. So that's what's up next. So return. The challenges and complexity of scaling back business to normal as the crisis subsides. The keys to return from a global perspective are really kind of have been honed in. I don't know if a lot of people have been watching Governor Andrew Cuomo speak, but he has these excellent talks every day really regarding the New York State response. And when we talk about return, he says it in every single one of his presentations: testing, testing, testing. Antibody testing, accurate, so high sensitivity and especially specificity for virus testing, and scaling it to our population. So not only our healthcare workers and our essential workers, but our entire state. Also herd immunity, contact tracing, as well as continued social distancing. So really, we won't be able to, the idea would be if we were able to find out what population really has actually contracted COVID, is positive for COVID, or now has antibodies to COVID before we return, so that we have an accurate idea. And if somebody is positive, maintaining or quarantining those people so that they're not infecting the rest of the population. When we talk about herd immunity, that we're really talking about 70% is the approximate number for herd immunity. So how do we get to herd immunity? There's two ways. One is the population gets infected. Ideally, we're not at the point where we have 70% of the population infected. So for 300 million people, that's a lot of people that would become sick, even if we do have asymptomatic carriers. A vaccination is the other option. At this time, we don't have a good vaccine. There are some notes from Oxford for a little bit of an accelerated vaccine program, but really, realistically, we're not looking at 2020 as the year of the vaccination. And then contact tracing has become very, very important in this crisis, and understanding who got infected and who did they infect. So let's talk about recovery even more. So this image is from the McKinsey Institute, really looking at what we're in terms of non-urgent and non-elective cases, which are not going to change over time, versus our elective and time-sensitive cases and our elective and non-time-sensitive cases. So an elective and time-sensitive case may be a patient that has some type of cancer and needs surgery, versus a non-time sensitive patient might be a bariatric surgery. So here we obviously saw that these demands decline. We should see a much more steep increase in the elective time sensitive surgeries compared to the elective non-time sensitive surgeries. And so we'll see an increase in demand and surge over capacity, and then we'll resume back to normal. So let's look at, from a national perspective, what that means. Which ones are which? So black here, these are going to be the urgent non-elective cases. Those are going to happen. Those need to go to the operating room. And then the light blue is the time-sensitive cases, and the dark blue is the non-time sensitive cases. So we have a large amount of dermatological procedures that are in the backlog. They need to go. All the dermatologists and plastic surgeons have been waiting for a while. There's a lot of endoscopies, about a significant amount of urology patients, orthopedic and spine patients, general surgery patients. Basically, all of ophthalmology has been waiting for us to resume back to normal. ENT has significantly as well as peripheral vascular disease, and the cardiologists as well, and cardiac surgeons. So we want to return back to normal. How does that happen? So what I want to do is really look at this from the surgeon's perspective and the American College of Surgeons perspective. So the American College of Surgeons published recommendations as the ACS, American College of Surgeons, return roadmap. So when they talk about the roadmap, these are the things that they're looking at. Number one, timing of reopening. When are we going to reopen? There are certain recommendations for 14 days. There's certain recommendations. So 14 days in a geographic area where you have a decrease in the rate of COVID at that time, as well as we're able to, as a facility, be able to treat the other patients. Facility testing. The facility should be able to test and protect patients whenever possible and must implement a strategy. And I'll go into that a little bit more. Adequate PPE is going to be incredibly important. If you don't have enough face masks, enough gowns, and other PPE to protect your healthcare workers, you can't go back to normal. And then I'm going to talk about the rest individually, but case prioritization, management of the 5 phases of surgical care, collection and data management, and finally, mitigation of the second wave. So let's talk about case prioritization. There's a lot of surgeons here saying, I, as a surgical resident, think the same way, that my cases are the most important. And we all kind of hound Sean, who's the OR coordinator, letting him know how important my case is compared to the other surgeons. But really, at an institutional level, we have to find a way to prioritize these cases. Everybody does not have the same importance of cases. Also, we've seen in our own institution that if we leave it up to the surgeon's judgment, that the right cases may not be booked, and everybody does not do an excellent job in terms of stewardship for facility resources. So what we need to do is create a list of previously canceled and postponed cases. Then we need to prioritize that. And that's going to be tough. I don't have an answer to that today. I, the surgical resident, do not have an answer to that question. But as a college, one of the tools is going to be the MENTS, which I'll explain here. The MENTS is basically a tool that assigns priority based off of length of stay, post-op ICU need, a bleeding risk, surgical site and team size, and where the location is for the surgery, as well as how long you can wait, and the patient's medical comorbidities. So each of these, first, the timing and the needs has its own scoring system. The how long you can delay the patient has a scoring system, and the patient's medical comorbidities have a scoring system. What you see here is that there is different thresholds to allow for justifications for these patients to get an operation versus not get an operation. And these these lines or these thresholds can move over time. So in certain times, if we establish a number that's 65, so if you put your patient in and the number is 65, that procedure is not justified. Versus if it's a lower number, then it may be justified and may go and have a higher prioritization. That being said, I was thinking about spending a lot more time on the slide, but what I'm going to tell you is that this tool is not perfect. There is no perfect tool. to really be able to understand. If you put a Whipple patient in there, it does not give you accurate idea of exactly what's going on and which patients really need prioritization. So there are tools out there, but at the end of the day, we as an institution need to still come up with a plan. Next, we talked about specialties, case prioritizations, and a tool. Also, we need to somehow prioritize specialties. Then we need to find a strategy to give allotted time. And does this mean block time? Does this mean that every surgeon gets his or her block time back? Or does it mean that if there are no block times and we just get as many cases in as possible? We also need to do phase opening and capacity goals. And then the question is really OR availability. And this is really important. Are we going to be doing cases long-term, into the night? Are we going to increase our OR availability where really at 3 o'clock, as all the surgeons in this audience know, really the operating room scales back. They want to get to four rooms as soon as possible, and they're not really, don't have the staff. Are we going to be able to increase our OR staff and availability to be able to meet the needs where maybe at 6 o'clock we scale back so that more cases are going even into the afternoon, into the evening, so that we can come back and return and take care of all those patients that have been backlogged during this time? And then we need to really identify those capacity goals. Are we going to resume at 25%, 50%? And we have to decide on ambulatory cases versus outpatient cases, and what we're going to do. We can't just open all the operating rooms simultaneously because we might not have the personnel or the material at that time. So this needs to be very well thought out. And we really need to look at the adjunct issues in terms of OR time, which include housekeeping, nursing, anesthesia, sterile processing, engineering. All of those people really make surgeries happen, as well as the surgeons and the staff in the operating room. If those people aren't able to meet our capacity, if we're doing a bunch of colon surgeries and we only have 5 EEA staplers in the room, we can't do any more than that. So we have to understand that all of that has to help meet our need and meet our ability to return back to normal. So then the next thing we have to understand for operating rooms is the phases of care. So if we're going to be able to return back to normal, we have to make sure that we're ready in terms of each phase of care. The first one is preoperative. So in the preoperative phase, we have to assess the patient's readiness for surgery and the anesthesiologist. This is with the surgeon and an anesthesiologist. So we need to find out if this patient is COVID positive, COVID negative. And also, a lot of patients have been pushed back and have not been seen in 30 days. How do we take care of these patients? Should we do a telehealth visit to make sure that they're ready to go? Are we going to keep them in the hospital? How do we do educational classes to get them out of the hospital as quick as possible? And then post-acute care management. Are they going to stay in the hospital or are they going to leave? We need to think of these in the preoperative phase in order to make sure that we're able to to be ready for the huge flux or surge of cases that are coming. Next is the immediate postoperative phase. This is a guideline for the pre-interventional area related to a case. So when they arrive in the hospital, are we making sure that are we going to test them? Are we going to test their family members? Are we going to allow visitors? What are we going to do in that case? In the operative phase, we need to assess the pre-anesthetic and the operating risks in the actual operating room, because we can't have every patient that has a complication or has high risk of surgery end up in the ICUs and then we lose our capacity to have ICU beds. At the same time, as I mentioned, what non-essential personnel can be here? What about the medical students? What about other non-essential personnel? Such as vendors? Are they going to be allowed to come into the operative phase, intraoperative phase, or are we going to keep them out of the hospital? So these decisions need to be made. Post-operatively, we need to standardize some protocols to make sure that we really get these patients out as soon as possible, whether that's ERAS or any other possible way. And then importantly, post-discharge planning. So are we sending these patients home? That's the idea. That would be the goal, because there is a much less chance of contracting COVID, as we've all seen that these types of nursing facilities have high rates of COVID. And so we need to understand if these patients can go home or if they need to go to a facility and which facility to go to. So I spent a lot of time on 4 and 5 here. we also need to be ready for data collection and management. What does this mean? That means that we really need to have all of our, every COVID testing related number available to us and all of our new data available to us so we can really process what's going on. So, and every day we have to look at what numbers of beds are going to be available, ICU, floor beds. It's always been important. This capacity management is something that our hospital does on a daily basis, and people are very, very good at it. And I commend them for it. Now the game has changed because there's a new variable that's been added, and that's COVID. And COVID is really eating up a lot of our capacity, and COVID can flux our capacity at any given time. So really understanding those metrics is going to become very, very important. And then making sure our institution has the ability to really respond to a second wave. So are we going to implement social distancing policies? What are we going to do for visitors? What, there's every facility should have their own policy in regards to that, and what we should do with the peri-procedural area. So we've really spent a lot of time talking about the resolve, the resilience, how we're going to return back to normal. What I really want to spend some time on now is going to be reimagining our future of medicine, and then we'll talk a little bit about reform. So we have the most unique opportunity ever to reinvent medicine. This is my silver lining for the pandemic. What we're looking at is we had to adapt, as I mentioned before, we really had to adapt as fast as possible to this pandemic. All of a sudden, the hospital we could not take our patients and admit them easily to the hospital. We had to care for them, but we had to find a different way. And we did it. We found different ways. We changed very, very quickly. How do we continue that? So what I want to talk about is I'm going to look a little bit into the past and say, why didn't we do this future? Why were we so slow? And how can we go forward from here? So there's 3 broad themes that really talk about why we were so slow and why telemedicine and telehealth wasn't working before. Because all of a sudden we're doing it. We're doing it within a month. So number 1 was a failure to appreciate telemedicine as not a new type of medicine, but rather a care delivery mechanism. Number 2 is providers, health systems, and payers were too slow to embrace change. Number 3, we need to understand that healthcare systems are really interconnected. So there are 5 real myths to telemedicine. And I'm going to spend some time breaking these down and tell you exactly what was going on before the pandemic and what we're dealing with now. So the first one is telemedicine was too hard. The second myth was patients prioritize relationships over transactional care. The third one is we can't do telemedicine. The physical exam cannot be redefined. Then number 4 is virtual visits are just not effective. We can't do those. And number 5 is there was no business model for this. And if there was a business model, it just did not pay enough. So first one is my favorite, which was telemedicine is just too hard. That was really the reaction to this, why we didn't do telemedicine. You know, first, before I even start talking about this, I really want to note the tremendous job from our IT department in making it happen at Christiana. It turns out, so I have a quote here. This is from the New England Journal, from JAMA. It says, it turns out that when fear of catching a potentially fatal disease strikes, telemedicine is no longer hard. Guess what? Everyone has a cell phone, and ease of use is everything. So let's talk about everybody having a cell phone. So these are this is from the Pew Global Study in 2018, looking at cell phone and smartphone uses throughout the world. I remember when I visited my uncle in India, and he told me this specifically. He said that a man may not be able to afford a shirt to wear, but he'll definitely have a cell phone and maybe 2. And that's really the case. Everybody has a cell phone. These are the 2018 numbers. It's 2020. Look at the number of people here that have cell phones. In South Korea, everybody has a smartphone or a mobile phone. The United States, 81% have a smartphone, and only about 13% have a mobile phone, and only the 6% have no mobile phone. And those numbers are even smaller and smaller today. So what we're looking at is these almost 100% of US adults having smartphones. So it may be just Dr. Harrod that doesn't have a smartphone. But what that means is that really technology's in our hands now. We can use iPads, we can use cell phones, we can use computers, we can use any type of technology possible to really meet these patients and deliver care very, very quickly. A Jefferson Health study found that in their staff for first-time callers, the call completion rate was about 100%. Can you believe that? 100%. Patients don't show up to our hospital and show up to their own office clinics most of the time. What percentage of your clinic patients are no-shows? Whereas this is much more easy, and ease of use for patients is everything. So that is incredibly important. The other thing they noted in that study is that these patients were incredibly happy with their outpatient visits, and they had a net promoter score of about 50 to 70 with their scheduled visit. What is a promoter score? Well, it's a management tool that can guide a loyalty of a customer to the firm or to the corporation. And looking at 50 to 70% means that they're either neutral or saw it favorably, which is a good sign. Nobody's seeing this in a negative light. And that, second, prioritization of patients. So there's a myth that patients prioritize existing relationships with their providers over episodic care. You know what? During this pandemic, we realized patients just want to be seen by a doctor or a physician extender. They just want care. What we're looking at is falling primary care visits coupled with growing emergency department and urgent care visit rates, which say that this is before the pandemic. So people weren't seeing their primary care providers, and they were going to urgent cares, emergency rooms, because that was convenient. They didn't have time to go and see their primary care provider. They didn't prioritize this existing relationship. They wanted to be seen. So how do we do that? I still believe that having a relationship with a patient is paramount, but the patients want convenience. So how do we find convenience? And that's with telehealth. And the next myth was that we can't do a physical exam. And I want to, really, telehealth is, you can do a physical exam, but I really want, when I was an intern, my chief resident, Dr. Weinberger, had actually done a really good grand rounds on the death of the physical exam. I think that there is a role in some certain situations, but at the same time, the physical exam can change in telehealth. Really what it emphasizes your ability to understand general appearance, like, the physician's gestalt. You walk into a room, I can tell you, is this patient sick or not sick? That's what my years of medical training have been able to do. That's why we go through training, so understand that a lot of patients. So sick or not sick, weight, are they in distress? What's their respiratory effort? We also get this amazing understanding of the patient's environmental factors. You get a sense of the environment. Where are they sitting while they're talking to you? Also, you can do a physical exam. Self-taught physical exams allows for risk stratification of patients that are truly critical. You can tell a patient and do a 4-quadrant exam, abdominal exam on a patient. You ask them to palpate themselves, or you have their own family members assist in your physical examination where they press down. You can look at a surgical site and really look at the incision and understand. So the physician's and mindset needs to change. What you can document is the patient is speaking without difficulty. They have symmetrical chest movement noted by video chat. And then by the patient's family member palpation, you can get a good abdominal exam, and you can really look at your incision and bring that camera close by and see what hurts and what's going on with that incision. The next myth is that virtual visits are less effective. This is a false dichotomy. So there's no comparison with virtual and in-person visits. It's apples and oranges. What we need to understand is that there are different visits tailored for different things, different needs of patients. So during this pandemic, there was only really one option, or two options: no care or virtual care. In the future, we'll have more options. And so it really is going to be patient specific. I'm going to keep saying that. Telemedicine is very, very patient specific. So what I want to really go over here is the understanding of which types of meetings are going to be excellent. So maybe a patient that lives 2 hours away that's going to come to your office to be seen for maybe a liver cancer, and they drive 2 hours and come into your office to develop to talk to you, but they don't have labs, they don't have testing, they have no CT scan, or they didn't get their CT scan but they got everything else. Wouldn't it be ideal for that patient not to show up to your office and say, well, I'm glad to see you, but I don't have a CAT scan, so you're gonna have to come back after your CAT scan, and then we'll have to rediscuss surgery. What if we could have a 5 or 10 or 15-minute televisit and explain all the needs and say, okay, I see that you got your labs, I saw you got this, get the CAT scan, then we'll meet in person and have a full discussion. What if at the same time, there are certain visits where you're looking at a abdominal aortic aneurysm after repair 1 year later, where all you do is you get the patient an ultrasound. They live 4 hours away or 3 hours away, and it's a difficult time to get care. They get an ultrasound at their local facility, and you review the ultrasound and you say, your repair looks excellent, there's nothing to do, I'll see you at another year, and we can have a discussion in regards to follow-up visits. This type is the ideal types of patient visits. So telemedicine is going to be for the right patient and the right encounter at the right time. Blood glucose testing. You saw the patient in the office. You want some follow-up. It doesn't need an in-person visit. Let's just talk about the numbers. Pull out your book. We'll talk about the numbers. I changed your Synthroid. Let's just make sure you're doing okay. Make sure you don't have 1 or 2 types of issues, your A1C, your cholesterol. Reviewing diet restrictions, the CAT scans, which I mentioned, and many more. The emergency general surgery clinic for us is an incredibly busy place. There's a lot of patients where we are really reviewing the pathology because they had an appendectomy. They won't see us for 3-4 weeks because the schedule is so tight. They obviously have not had any complications or have not mentioned it. Those patients probably don't need to drive in just to see that. We can review their pathology, make sure they're doing all well, and really offset the really sick patients with drains, with severe diverticulitis and other problems that need to be seen in the office. Finally, the fifth myth is that there's no payment model. What I'm looking at here is the telehealth CPT codes, and we're looking at the average amount charged and the average amount estimated allowed. And so there are CPT codes. Unfortunately, they really go to a level 3 visit. There are level 5 visits, but really it's not the same. We are getting physician payment during this time for telehealth, and these are the COVID payment models, and there are non-COVID payment models as well. We still need a lot of work, but at the same time, there is a payment model which we had to create during this time. Everybody had to create it to address the pandemic. We have a small foundation. It's time to move to the future for that. So really those broad themes where you have to understand that telemedicine is a healthcare delivery mechanism. We've embraced faster change now. What I also want to mention is that healthcare organizations are really interconnected, that we're able, if a patient needs to see one provider in one health system, our current liver, if we need a liver consult for a hepatologist, we really need to go to Albert Einstein to have the physicians there take a look at our patients. A lot of times our hepatologists are driving down to Christiana. Do they always need to drive down to Christiana? We really need to understand that all these healthcare systems are very interconnected, and this allows for excellent use of telehealth. And finally, I want to mention that telehealth is very patient specific. So in 2002, there was a book that came out that really discussed the understanding of global economics. Thomas Friedman wrote this best-selling book called The World is Flat. What I want to tell you is that the healthcare world is flat as well. So what we've seen here is that the best example is really New York State, that all of our healthcare systems are really interconnected, and we really need to understand that when we talk about the COVID response, that in certain surges in COVID in New York City, in order to take care of some of the patients inpatient, they had to flux other hospitals in different parts of the state, and that each part of the state really affects different parts of the state. We also understand that supply chains are much more dynamic. What I mean is, when I say that the world is flat, is that there aren't mountains, that each healthcare system is not a complete isolated silo, that everything is very, very dynamic, that if China is not able to supply certain types of medications or drugs, then we will have to go somewhere else. But that ability to go somewhere else is much easier. You don't have to climb 2 mountains to get to that point. Healthcare institutions must talk to each other and must talk to the local, state, and federal governments. We saw that with the COVID pandemic. We need to continue that going forward. And also with telehealth, what we need to look for in the future is how data sharing really becomes seamless. At the same time, while it's seamless, we have to understand that there are HIPAA privacy laws that we have to take into account as well. But really, being able to show which hospitals have increased capacity for trauma, for certain types of patients in the future is going to be incredibly important from a large institutional level. So we've really talked about resolve, organizational resolve, resilience, return. We reimagined the future of medicine. And finally, I really want to talk about reform. So what is reform? It's time for change between the government, businesses, and individuals. I'm going to hit on a few topics here. First, we have to accept new monitoring techniques. So this is going to include understanding that global health systems as well as national health systems are going to have to find new ways to monitor patients. Whether that means that taking blood pressures at home and sending them to a computer and making sure that they're stored in the correct place, and other ways of monitoring these patients and sharing that that data. Next one is really data interoperability as a renewed priority. What that means is that we really need to understand this data and be able to share it properly. Then next one is really strategic reserve of supplies and agile manufacturing. I mean, this was paramount. We saw that there are certain things that we're going to need in every pandemic. I think that this is incredibly important. In 2015, Bill Gates was asked what his greatest fear for the world was, and he said he was very, very scared of that a pandemic was the scariest thing he could think of. We weren't ready. There's been people talking about it. The Netflix series, A Pandemic, has talked about it. But as an institution, as a global healthcare system, we weren't ready. Now it's time to be ready. Strategic reserve of supplies like PPE and making sure that manufacturers understand that, hey, at any given moment, you might have to change what you're manufacturing in order to meet the next pandemic that comes. Establishing a medical force, emergency medical force. This has to come from a local, state, or federal level where people are able to really come in and respond. It's excellent to have the military, and one of the best examples is really the Comfort, the Navy ship. That's excellent, but that's just one thing. What if we had a medical force that could be deployed in different locations and was agile enough to be able to help the next pandemic? Creating a multi-layer coordination response on a federal, state, local, and institutional level is going to be paramount for this pandemic as well as the next pandemic, and really creating a seamless transition where people are talking and these task forces are sustainable. You don't just wind down the task force, but you create a committee that talks to each other and is ready for the next pandemic. Really standardization of fragmented medical systems. We've seen patients are moving across the world so rapidly. A patient that had COVID in China went to Europe, that person went to New York City. There's people that went all over our country. We can't have our healthcare systems not talking to each other. And this means that we need to find better ways like DIN of having our different hospitals and healthcare systems talking to each other. And finally, heightened expectations of financial protection, really, being ready to survive from a financial perspective, the next pandemic, and being resilient through that. So our institution has done an amazing job. I'm very, very, very proud to be a member of Christiana and to be a graduate from this institution. I think our organization has shown an amazing institutional resolve. We've been tough through these tough times, and we've really survived it. And it's really to all of you and the rest of our healthcare organization and our leaders. I think we have a plan to return back to normal, but there are a lot of questions that are still left that we need to answer before we get to that point. And we need to break down each part of those questions and make sure that we have a plan, and that plan is flexible. If that doesn't work, then we'll try something else. And that's how we'll return back to normal. This is the most unique opportunity of our healthcare careers to really reimagine medicine. COVID came in and basically, blew the entire house down. And while we're rebuilding it, let's build it without walls. Let's build it so that everybody's talking, that things are seamless, that everything becomes truly patient-centric, where it's actually convenient to the patient. And it's convenient, and we're doing the right thing for the patient. If that means just having a quick 5-minute visit, then that's what it needs to do through telehealth. Or if it means meeting in person, it means meeting in person. And understanding that we need to create better apps and different IT support to allow that infrastructure. And finally, getting the government from federal to state to local and our institution to really reform from a policy and a legislative perspective to be able to meet the next pandemic that comes. So it's been amazing to be at Christiana. I really think that it's just been awesome. So I leave you guys with this quote. It's from one of my favorite bands, Matchbox 20. I believe the world is burning to the ground. Oh, well, I guess we're going to find out. Let's see how far we've come. Let's see how far we've come. And I think we've come incredibly far, and our future as an institution is incredibly bright. And I thank you really much for this opportunity to speak in front of you guys. And I really yield the floor for questions.
Priyam, that was an amazing talk. I really appreciate your hard work in giving us this update. I've 2 questions and comments, and then we should open up to the floor. The last part of your talk where you discussed how far we've come. We have our multidisciplinary clinic, as you know, and there are a lot of providers. There's about 10, 12 people sometimes at like our hepatobiliary. And we did one by Zoom last week, and we had 4 physicians, nutritionists, social work, pain and palliative psychology for somebody who is actually too weak to leave his home. And we were able to provide proper medical care. Although we didn't intervene, we treated this person like a person, and we were able to render a very good comprehensive opinion. So I think we've made some huge strides in taking care of patients, and that would have never happened. My concern, and you sort of mentioned this in one of your last slides, is we're sort of getting to the point where we're entering into George Orwell's 1984. And there are drones that are flying around telling people to go inside. Google and Apple are working on a tracing app, and I understand the importance of tracing, but what else is that going to be used for? And for those of you who haven't watched the documentary, The Big Hack on Netflix, I highly recommend it because it really talks about the dangers of companies getting big data. And here we are opening up more data, which we have to do for tracing. And when you combine that with the drones, my daughter's just 16 years old. She watched this drone on the TV the other day, and her eyes went wide, and she said, "We just read about this, in school." It's very concerning, and I mean, it's going to happen, but it's going to open up some parts of the world that maybe we don't want opened as well. So there's not going to be just good things that come out of this. There are going to be some concerning things as well that we're going to have to pull back on when the pandemic ends, if you want to make a comment on that.
Priyam, we can't hear you. I think maybe your mic is
muted.
muted.
Yeah, are you muted?
Yeah, I was muted. Sorry.
All right.
So just to, we have, it's a really interesting time because we have a lot of new players in the game. We've always had the federal government and the state governments in terms of CMS. We've always had the private and public insurers. We've always had the healthcare institutions and the ACOs. But now we have the Apples and the Googles coming in. And they think they're big tech. Big tech is coming in, and a lot of investment firms are coming in, trying to and trying to pair with different organizations like CVS to kind of change what they see as the next healthcare model. I think protecting healthcare privacy is going to remain paramount. There's been lots of talk about how we can do that, but I think that physicians and as a healthcare system, we've done amazing jobs in terms of health HIPAA. What we're able to do in terms of keeping people out that aren't supposed to be looking at patients' health documents has been amazing. These people don't play by those rules. They want to make money. So we really need to push the government to be able to maintain our HIPAA and really find a new way, legislatively speaking, to really meet those needs. Because I understand contact tracing, but you can't. That's always been one of those weird things. Where does individual privacy stop for global or wellness, or for a community wellness? And that balance, we as a healthcare community need to keep speaking out for healthcare privacy.
Any other questions?
Al Bacon, just one comment. That was a superb talk. Number one, you not only gave us some good data, and I agree with your telehealth discussion, but you also challenged us to think ahead, and that is the mark of an excellent discussion. So thank you so much. I really am pleased to have an opportunity to see it today.
Thank you, Dr. Bacon. Thank you for coming today and for moderating our talk about a month ago. I really appreciate it.
Any other comments or questions? All right, Priyam, do you have any other final comments? Otherwise,
Actually, Joe, is Dennis Whitmer. I had one
sure. Great
comment. That was a remarkably outstanding talk from an organizational perspective and a logistical perspective. I think the questions are many. There will continue to be a certain number of COVID patients that we have to encounter even after the pandemic subsides. And we really don't know what that new normal is going to look like and how we're going to prepare for that. And the ability to change and to flex and to adapt is going to be critical as we move forward. And I just think that you have set the tone for how we continue to change as the demand needs to be changed. So I want to thank you for putting that all together. I thought it was just tremendously outstanding talk. Thank you.
Thank you.
Priyam, could you display the code for CME again, please?
Yeah, definitely.
Thank you.
Any other questions?
Thanks for the talk.
Yeah, that was great.
Thank you.
Excellent presentation. Really enjoyed it. Thank you so much for switching your topics.
Thank you very much.
You got to think about writing it up.
Yeah, I think Dr. Petrelli, I think that's a great idea. I actually have a nice manuscript already. Like basically, it's just all my notes. So I really don't have to do too much from it, besides kind of make it look medically acceptable from a literature standpoint. But I'll definitely work on writing it up, sir, and try and submit it.
Great.
All right. If no more questions or comments, then we can end grand rounds.
Excellent. Thank you, everybody, for coming. And thank you again, Dr. Bennett, for everything. I really appreciate it. And I think there's going to be another grand rounds in a couple of weeks. Same format, same style, same everything. So I appreciate everybody coming.
Thanks, Priyam. Excellent.
Thank you.
Stay safe.